So we have a very busy afternoon and evening, so we better start. And again, thank you very much, Professor Jan Bakker, for accepting our invitation. Your previous talk on lactate was watched by more than 160 people. And today you're going to talk about capillary refill time, peripheral perfusion as a resuscitation target. And we're really looking forward to it. So without any further ado, Jan, thanks very much for being with us. Please share your screen. And although we are only a few here in the studio, but there are more and more people online. So we are really excited about your talk.
Okay, thank you very much for the invitation again to present in this very interesting initiative to, let's say, give free access for everyone to, let's say, more or less experts in the field. Whether I'm an expert, you can maybe assess at the end of my presentation. Now, how to use peripheral perfusion parameters in clinical practice. That's a huge topic because, I mean, I could cover, let's say, every clinical context where you could use it, and then I could cover every, let's say, parameter of peripheral perfusion, and then I could cover the whole physiology. I try to condense it a little bit, and I'm always open to questions, either by email afterwards. I want to draw your attention to two other interesting initiatives that are not all free. This is a course for the European Diploma on Hemodynamic Management and Monitoring of Patients with Shock. It's an extensive program. It's 5 sessions starting in November, and it ends with a week of teaching and simulation in France. If you have any questions about it or you want to register, then send me an email because the link of this course is a little bit complicated. This one is also free, well, more or less free. It's a discount for residents and junior staff members and nurses. It's also about hemodynamic monitoring and perfusion. It's 3 days, and it's mainly, or it's focused from 8:30 to 14:30 to be able to have everyone in the world where possible to join. Also, a lot of speakers and a lot of topics. So there's nothing much new in abnormal peripheral perfusion. Don't think that we invented this in the last decade or in the last 2 decades. This is old stuff. Why? This is a painting of Lord Nelson, who died in 1805, centuries ago, on the deck of the Victoria. And of course, there was not a painter there drawing this picture, but the people told them what happened. And what you can see is that the dying Lord Nelson, his face was very white. And when you look at the others, there was this red blush. Everyone had some red blush on their face, except for the dying Lord Nelson. So already centuries ago, they recognized that if you were in a terrible condition, you would have a pale face. 40 years later, in 1843, there was the first description of lactate. And in this paper by Joan Shearer, he was a laboratory guy. He did the first measurements in patients, and very sick patients. This was a young 23-year-old dying while giving birth. And he measured lactate, and he described the clinical picture. And look at this, cold extremities. Already in 1843, they found that this basically patient dying of sepsis in this case. already had not only the rapid pulse and sweaty and anxious breathing and the mental state abnormalities, also a very important sign, but also these cold extremities. And I think if you come to the bedside of a patient and you see something like this, so either very pale with blue nails or very blue or this mottling, you should be concerned. Whatever is going on, whatever the diagnosis is, whatever the time of the day, this is a terrible emergency. Now, there are many ways to, let's say, assess and monitor, because if you want to monitor, you have to do repeated measurements. And of course, capillary refill time, which has gained much more interest since we did the Andromeda 1 study. But there are many. It's also subjective temperature. It's color. You can use more, let's say, non-biased elements and parameters like the temperature of the toe. This was basically the beginning of clinical critical care. I will come back to that later. So peripheral temperature or differences in temperature, central to toe or proximal to distal. And then, of course, you can, if you have money, you can add devices. The peripheral perfusion index, which is derived from the pulse oximetry signal, you can use a near-infrared device. You can use a microcirculation scan under the tongue, the very old one, OPS, or the SDF, or the microscan, or the very latest one, the Oxygenation. Laser Doppler flow, we have exciting research going on here in Chile and Colombia, where we can identify the role of the nervous system and the myogenic system in peripheral perfusion using laser Doppler flow. So that's, let's say, expensive and more labor intensive. This, of course, is extremely simple. You look at the patient, you feel the temperature, you press in a finger, and you're done. You can do this everywhere in the world. And if you want to do these advanced techniques, of course, you need money to buy these devices. Now, why is the peripheral circulation interesting? Because it's so much under the sympathetic nervous system control, just like the intestinal circulation. Skin perfusion is very much controlled by sympathetic nervous system. And of course, you need your sympathetic nervous system when you get into trouble. That's the first thing that will happen if you start bleeding or if you have a myocardial infarction. Your sympathetic nervous system gets activated to maintain your blood pressure, basically maintain your blood pressure by vasoconstricting the not very essential areas. And of course, intestinal is also not very essential when you're in trouble. If you want to run for a lion that's chasing you, you're in no need of having intestinal function. The problem is, if it persists, then of course you're in trouble, because if this goes on for a long time, you get intestinal ischemia. I will come back to that later to show you the clinical relevance of this. Now, what is this peripheral? What is this vasoconstriction sympathetic nervous system doing? Shutting down blood flow to non-essential circulations. And non-essential is non-essential in surviving the immediate threat. So the lion that's chasing you and stuff like that. This is a patient where we had severe intestinal GI bleeding, and we couldn't find the source. And so we went to the, this is a long time ago. So we went to the radiology and we did a scan with contrast. And as you can see, this severely bleeding patient with significant vasoconstriction. There is no perfusion of the intestine. There is no perfusion of the liver. there is no perfusion of either of the kidneys. And so this is what we would call a central circulation. So the blood goes through the aorta and back through the vena cava without perfusion much. And that's, of course, something that you could simulate in the lab. This is a pig. And so what we did in these pigs is we introduced obstructive shock, so a tamponade by infusing fluid in the pericardial space, or we induced septic shock by giving an infusion of endotoxin and wait. That's the only thing we did, just wait. And there are two important elements in this. Of course, if you increase the pericardial pressure, you will decrease venous return and cardiac output will drop. And then when you release the pressure in the pericardial space, of course, venous return will increase and cardiac output will return. That's one element. The other important element is in sepsis, and I won't go into this completely because I would need much more time. If you give endotoxin, and so have what is, let's say, an evolving sepsis, if you wait and wait, cardiac output will drop. And the mechanism, of course, is the vasodilation and the increase in venous capacity that will decrease venous return and thus decrease cardiac output. And so basically, every septic shock in the very early phase without any fluid resuscitation is a hypovolemic, is a hypoperfusion shock. Not hypovolemic because fluid doesn't disappear. The fluid is still there, but it's not functional in a way that it contributes to venous return. And if you resuscitate, the microcirculation, this is all microcirculation, doesn't come back, neither in the sublingual area, the intestinal area, or in the muscle. And it takes much more time. Now, this is an acute model with only a few hours. And so the endothelial damage, which is responsible for this delayed response when you compare it to tamponade, is of course limited. And so in clinical practice, we know that even if you restore cardiac output in septic shock, you cannot restore microcirculation. We will come back to that later. Now, what about human beings? This is a study we did with healthy volunteers. And what we did is introduce lower body negative pressure. So half of the patient is in a negative pressure chamber, and you can increase the negative pressure in the lower half of the body, which will reduce venous return. And so if you do a stepwise decrease in lower body negative pressure, you have a stepwise decrease in venous return. And so basically you introduce something like hypovolemic shock. Well, not really shock, because you won't put these healthy volunteers in a shock state, of course. I will come back to that in a minute. And so if you do this and you do a vascular occlusion testing, a little bit too much for this presentation, but it's a dynamic test of the circulation, the peripheral circulation, to a decrease or a shutdown in flow and then a reperfusion phase. So you increase the cuff pressure on the upper arm, you completely shut down the arterial flow to the lower arm. You measure an index or a parameter of perfusion. In this case, we did STO2, for instance. You can also use near-infrared, that's the other one, THI. And then you open up the cuff again after a few minutes of 3 minutes in this case of arterial occlusion, and you have this reperfusion. And you can see that lower body negative pressure, so introducing some kind of circulatory dysfunction at least, results in abnormal peripheral indices of perfusion. And it's not only, let's say, in this case, skin and muscle, but it's also microcirculation. So if you do microcirculation under the tongue, you introduce -60 lower LD negative pressure, decrease in cardiac output in these healthy volunteers. You will create an abnormal microcirculation under the tongue as well. And if you do the same and you measure heart rate, mean arterial pressure, and stroke volume, and so basically give more hemodynamics to the model, you can see that, yeah, it's indeed some kind of hypovolemic shock, because you have all the characteristics of hypovolemia, an increase in heart rate, a decrease in stroke volume, and when you turn the negative pressure off, everything returns to normal. This is interesting. This is the peripheral perfusion index, so it's the index retrieved from the pulse oximetry signal. It immediately decreases, and it doesn't further decrease. It's not like it's getting worse and worse with more decrease in sympathetic stroke volume, because it's the sympathetic nervous system that goes on, and boom, it's there, and it decreases peripheral circulation. Now, as I said, we need our sympathetic nervous system to survive. This is, of course, very limited because it's only -60, and you can see that stroke volume decreases from 116 to 74. So it's not a huge decrease, but still, if you already have your sympathetic nervous system fully activated, this is not something you can tolerate. Theoretically and in clinical practice, because what we saw, there was one guy who already was very nervous and a little bit anxious before the start of the experiment, and his peripheral perfusion index was already very low. As you can see, the others started around 8. He started around less than 1. And so he was already vasoconstricted. Then we decreased his stroke volume by increasing the lower body negative pressure, and he collapsed. He lost consciousness. And so what you can see is this is reperfusion. After we reperfused, so removed the negative pressure, there was a bump in his cardiac output. He had a rapid improvement in the peripheral perfusion, and then came back to his baseline state. So this peripheral signal is very helpful to identify patients that have some kind of abnormal perfusion, abnormal hemodynamics associated with low cardiac output, or abnormal regulation of blood flow, regional, microcirculatory, both. Depends on which parameter you use, a microcirculatory one or a more global one. And also, this is not very new. Already in 2001, Kaplan showed that if you looked very simple at the patient with a cool or a warm skin, so vasoconstricted, vasodilated, they had similar heart rate, blood pressure, and all these elements. But when you looked at when you assessed the cardiac index, the pH, SVO2, and lactate, you could see that cool patients were hypoperfusing relative to the warm patients. As you can see, the cardiac index is significantly lower. The SVO2, a marker of adequacy of blood flow, significantly lower, and the lactate significantly higher. So warm versus cool, very simple. You put your hand on the patient. If you think it's cool, that's associated with a completely different macrohemodynamic profile. That's already what Alexander Lima, one of my PhD students, showed a long time ago. And Aïtou Fella in France did also quite a few studies on peripheral circulation, first using this modeling score. Now he's completely into capillary refill time. But this is an interesting study of him. And of course, we know from clinical practice, if you have a blue knee, we don't get that excited and we don't get that concerned. But when you see a patient with something like this and the whole leg is blue, we know we are in trouble and the patient is in trouble. And as you can see, the odds ratio for mortality is 74. So only a kneecap or nothing is 1. And so the whole leg compared to this patient is 74 times higher chance of dying. And so, yeah, that's a definite emergency. It doesn't tell you what to do. Remember, all these parameters of peripheral perfusion, they don't tell you what to do, but at least they tell you to get concerned and to find out what's going on. And as I said, the temperature of the big toe is one of the elements, and it was introduced by Max Harry-Waal already a very long time ago when he did his studies in cardiogenic shock. And when Professor Waal died, we wrote a tribute to him, and we basically summarized one of the many elements that he added to critical care. And one was, of course, how do you recognize shock and what is shock? And Max already said shock clinically is illustrated by altered mentation, as I said, in the 1843 publication. The 20-year-old who got delirious while dying from what we now would call septic shock. So altered mentation, very important. The mottled and clammy skin was already something that Professor Waal introduced. Oliguria, patient at pee and stop here, is a bad sign. And so he said shock is hypotension, not necessarily, but generally it's hypotension. Increased lactate, very difficult to define a shock without an increased lactate. Altered tissue perfusion, all on the basis of microcirculatory abnormalities. And that's true. Those microcirculatory abnormalities are a real problem, even though we cannot always see them. But using simple capillary refill time can already reveal that your problem in the patient is bigger than you might think when you only look at blood pressure, for instance. This is a study we did with Andreas Brunauer in Austria. And we looked at 30 patients admitted to the ICU. And within 24 hours of admission, we measured capillary refill time. Capillary refill time is on the x-axis. And then with the Doppler measure of the variability in blood flow, we could assess the perfusion of the liver, the kidney, the intestine, and the spleen. And what we were interested in is what is the relationship between capillary refill time and this resistance index. And the higher the resistance index, the lower the flow. And as you can appreciate, in all of these regions, the longer your capillary refill time, the lower your flow. And so the flow decreases, so the resistance index increases, meaning the flow decreases to the liver, the kidney, the intestine, and the spleen when your capillary refill time increases. And so that's basically the basis for what Max Harry-Waal said. Shock is characterized by abnormal peripheral perfusion, abnormal capillary refill time. And yeah, if you have this abnormal peripheral perfusion, you have abnormal perfusion of your liver, kidney, intestine, and spleen, which is, of course, I don't need to explain, a serious problem. So that's all the abnormality. Now, how to use it when you start treating your patient. Now, for instance, Surviving Sepsis Campaign and many other guidelines use lactate to identify patients with shock. I think that's absolutely correct. Very difficult to define shock without having an increased lactate level. It's beyond the scope of this presentation. So you have a patient with increased lactate. You think there is a tissue abnormal tissue perfusion. You start treatment, and you see lactate decrease. That's usually what you see when you have the right diagnosis and the right treatment. And so this is the normalization of lactate, basically like the INR of lactate. And so within 6 hours, there is a significant normalization of lactate in many patients. And interestingly, this normalization of lactate coincides with an improvement in the delta PCO2, which is a marker of cardiac output, and relates to a rapid normalization of capillary refill time, not in everyone, in many patients. And so these two flow parameters coincide with this rapid normalization of lactate. And of course, then you're in trouble with lactate. There is no discussion that if you have lactate and hypoperfusion, that this is related to mortality. But having an increased lactate, let's say more than 6 hours after you did your interventions and you normalize your flow parameters, this lactate is not hypoperfusion anymore. In this study, these are all survivors. We excluded the dying patients. So these are all survivors at 24 hours. 50% still had an abnormal lactate. And so be careful when using lactate at these, let's say, later stages, in this case, septic shock patients. More extreme and, of course, much more difficult to use, but just to illustrate that this peripheral perfusion abnormality is still related to global hemodynamics and microcirculatory hemodynamics, even if you mess up with the periphery. So, as you know, in cardiac arrest, we cool patients. If you cool a patient, I can't show you the studies that we did, but Alexander Lima and Michel van Genderen did studies where we cool the periphery, and then you see all these markers of peripheral perfusion getting abnormal. Now, that's what we do in cardiac arrest. We cool the patients, and so we make the capillary refill time or the temperature difference in the skin abnormal by definition. But interestingly, in the patients that ultimately die from cardiac arrest, they are abnormal, just like the patient that survived, but they stay abnormal. So these are the patients that die. And so they're both abnormal, but they're more abnormal in the patient that ultimately died, the green ones. And so this is what you could say, this is the induced abnormality with the, let's say, intervention, cooling. And this is the added abnormality due to the abnormal circulation in these dying patients. And so in the very extreme elements of this peripheral perfusion, it is still telling you something about the condition of the patient. Of course, mortality has many aspects, but still, if you have a capillary refill time of 15 seconds, even if you cool the patient, something is probably wrong. That's basically the message. Now, there's a lot of discussion on using capillary refill time, and many see capillary refill time as a very subjective parameter. That's why in Andromeda 1 and in the current Andromeda 2, we use a stopwatch and we use a glass to push, not on the nail bed, but on the other side of the finger to make it, let's say, less susceptible to bias. Of course, in clinic, I never use a glass to measure capillary refill time. I press on a finger and then you do 1, 2, 3, 4 and count seconds. I agree, completely subjective, because if you have a warm and well-perfused patient, you would do 1, 2, 3. Yeah, no. And if you have an abnormal patient who is mottled, well, I don't do capillary refill time if you're mottled. That doesn't add anything. But you have a patient where there is no clear skin abnormality, and you think the patient is very bad, you do you count different. You do 1, 2, 3. Yeah. So that's what we did in this study with Michel van Genderen, and we used 5 seconds. And so we increased the time. In Andromeda 1 and 2, we used 3 seconds for abnormality. In this study, we used pressing the index finger for 15 seconds, and we used the clock that's basically present in any patient room, and it's an analog clock. And so it's a moving arm of the clock. So susceptible to a lot of bias. And then we used different observers, and we calculated the kappa between the two. And if you use 5 seconds, it's reasonably consistent between different observers. So there is, of course, no clear objectivity. It is susceptible to bias and to inter-observer and intra-observer problems, but still in clinical practice, it works. Now, does it identify patients that are doing very well? Of course, we are still in the treatment phase. So the patient comes in. In this case, we did a study at Santiago, patients with sepsis in the emergency room, and they had abnormal capillary refill time, and then we gave fluids because they at that time still did surviving sepsis campaign. So sepsis meant give fluids, and on average they received about 1,700 ml. Up to 2 liters in these patients. So they tried to comply with the 30 ml per kilo at that time. And on average, the capillary refill time normalized and lactate decreased a little bit. But the interesting thing is, the patient that normalized their capillary refill time with this initial treatment of sepsis had a much better prognosis. The likelihood of dying if you corrected your capillary refill time with fluids only was very low. The mortality in this group was around 8%, 9%. Whereas if you did not normalize your capillary refill time with fluid resuscitation only, more than half of the patient died. And so having this capillary refill time, having your standard treatment, whatever your treatment is, if your patient responds with normalizing capillary refill time to the treatment you instigated, that's a very good sign, given this study. Now, you may know that in the Netherlands, we're very fond of nitroglycerin. And so if I see patients like this, took me a while to convince them in New York that nitroglycerin is helpful in these cases. Took me about 5 years to be able to convince them to do the first patient. But if you do this and you give a little bit of nitroglycerin, you turn this into something like this. Of course, if you don't add an infusion of nitroglycerin, a few minutes later, this is completely back to the original state because the half-life of nitroglycerin is very short. Together with Alex Lehman, we did this study already a long time ago, 10 years ago already. And we looked at an increasing dose of nitroglycerin and looking at peripheral circulation. I won't go into the whole protocol. The highest dose was 60 milligrams per hour as a maintenance dose. There is a small decrease in mean arterial pressure because nitroglycerin is also a venous vasodilator, so it increases venous capacitance, and so your cardiac output goes down a little bit. Sometimes we give a little bit of fluids In this case, we didn't, and you can see there is a small decrease in cardiac index, not significant, but still. So there is some vasodilation in the, let's say, macro hemodynamics as well, giving you a little bit of hypertension. And as you can see, it immediately returns when you stop the infusion. The interesting thing, of course, is that in the parameters of peripheral perfusion, we use capillary refill time, index log, skin difference, STO2, the upslope of the vascular occlusion testing. In all of these patients with circulatory shock, this was all shock. It was all abnormal at baseline. It significantly improved in all with nitroglycerin, and it significantly decreased again after stopping nitroglycerin. So that's the pure vasodilator. We talked about using nitroglycerin in Andromeda 1, but I have to be honest, if you're not experienced with nitroglycerin, it could end up in dramatic changes in macrohemodynamics, so you have to be careful. That's why we chose for dobutamine in Andromeda 1 and not nitroglycerin. Now, if you assess your efficacy of your treatment by using capillary refill time, and so do not resuscitate the patient with normal capillary refill time or normal peripheral perfusion, and resuscitate the patient with abnormal peripheral perfusion. That's a proof of concept study Michel van Genderen did in 30 patients with septic shock. And so if the peripheral perfusion indicators, capillary refill time perfusion index, and the near infrared, and the delta temperature, if 3 out of these were abnormal, we said then you have clearly abnormal peripheral perfusion, no discussion. It's somewhat biased and very unbiased measurements of skin perfusion. If these were normal, we didn't do anything. And if these were abnormal, we gave fluids following surviving sepsis campaign or whatever was needed to improve macrohemodynamics. And the result was that, of course, in the protocol group where there was normal peripheral perfusion, we would not give fluids. In the control group, peripheral perfusion was not measured, and surviving sepsis campaign guidelines were just followed, whatever the peripheral perfusion. There was significantly less fluids in the protocol group. And so, and you could argue, well, a little bit, a liter less of fluids, is that very relevant? Well, they also had less organ failure. And I will come back to this at the end. That, of course, makes sense as well. And so limiting your therapy, your resuscitation efforts in patients with normal peripheral perfusion is associated with less organ failure. Of course, in 30 patients, it doesn't make sense to discuss mortality. And that's why we ultimately started the Andromeda 1 study already some time ago, now 5 years. We're now doing the Andromeda 2 study. This was Latin America, and the current Andromeda and the randomized 424 patients. The current Andromeda 2, which is basically a repeat with a little bit of change in initial treatment based on perfusion pressure and diastolic blood pressure. I won't go into that. But in this study, we compared using lactate to guide your treatment or capillary refill time. And as you probably know, there was a p-value of 0.06 in the difference. So it was not statistically significant when we did a Bayesian analysis. It turned out to be much better to use capillary refill time than lactate. We did a lot of subgroups as studies where we showed that indeed using capillary refill time seems to be better than lactate. That's why in Andromeda 2, we do not use lactate anymore. So in Andromeda 2, we do either capillary refill time or your standard, whatever you do in your hospital. You can use lactate, surviving sepsis campaign, whatever you want. But the protocol group is capillary refill time. Now have just over 1,250 patients. Interim analysis is due in 1 or 2 weeks. And if the study is not stopped, we will probably end the study early 2025. Now, part of this study, Andromeda 1 and 2, is how to treat the abnormal peripheral perfusion. And what we introduced is first fluid responsiveness, use fluids to optimize. If fluids don't work, then in the chronically hypertensive patient, use the vasopressor test. So the theory is if you're chronically hypertensive, you might need a higher blood pressure to maintain tissue perfusion. So we increase the blood pressure to 80, 85. If capillary refill time normalizes, we keep the higher blood pressure. If not, we'll return to baseline. If you were not chronically hypertensive, we use the inodilator test. So instead of the nitroglycerin, we used either milrinone. Nobody used milrinone. The majority used a low dose of dobutamine, which of course is also a vasodilator. So that's the 3 steps in the resuscitation protocol: fluids, vasopressor test, and the inodilator test. We're now working on a new study where we probably will skip the inodilator test as well. We're studying the different aspects of the vasopressor test. We just finished a study where we compared doing a vasopressor test with either norepinephrine or vasopressin. Extremely interesting result, of course, outside of the scope of Andromeda 2. But even if Andromeda 2 is positive, we still need to learn much more. So to sum up, you have a patient in shock, should have high lactate. The first question you should ask yourself, is this indicator of shock maybe due to something else? Because if you have seizures, diabetic ketoacidosis, or you have a Warburg metabolism or intoxication, you have lactate, but doesn't mean you're in shock. So if you think, yeah, this is something completely different, then of course act accordingly. If you think, no, this lactate is absolutely related to the shock, then measure a peripheral perfusion. If peripheral perfusion is normal, that's already interesting. If you still have doubts, then measure the SEVO2. Take a blood gas from your central venous catheter. If this SEVO2 is also normal, then measure a delta PCO2, the CO2 in your central venous or your central venous line or your mixed venous line versus the arterial delta PCO. If this is also normal, so everything is normal, then you have to rethink. Are you sure that this is really shock? And what we advocate in this paper we published in Intensive Care Medicine some time ago, wait and see. Remeasure lactate again. If you're still worried about your lactate, remeasure and see what happens. If your delta PCO2 is abnormal, then you have a flow problem. Increase flow and measure delta PCO2 again, and your lactate should decrease, and then you wait and see. If you increase your flow with fluid, dobutamine, or whatever you use, but lactate doesn't change, then rethink again. Is there maybe another source of your lactate? If your peripheral perfusion or your SEVO2 is abnormal or low, you have a flow problem. It doesn't tell you what kind of flow problem, but you have a flow problem. So solve the problem, lactate should decrease, and then you wait and see. If you increase the flow and correct the SEVO2 and peripheral perfusion parameter, you do basically the same. You measure, and your lactate doesn't change, you do delta PCO2 again. If your delta PCO2 is still abnormal, you have to work harder. You have to increase the flow even more. that should lead to a decrease in lactate. Remember, this is all early. This is not 24 hours of resuscitation. This is in Andromeda 1, we used 8 hours. In Andromeda 2, we used 6 hours. This should be solved within 6 hours, not like 24 hours of treatment. That's why these studies in the first 24 hours, where patients are included in the first 2 hours and up until 24 hours after admission, this is not relevant anymore. So this is very early. And so if your delta PCO2 remains abnormal, you'll have to work harder on your flow. If your lactate still does not change, again, we think about other sources of lactate or problems in clearance. And you also can use the CO2 difference over the O2 difference, introduced by Gustavo Ospina Toscon when he did his PhD in Brussels with Jean-Louis, to give, let's say, more context to your lactate and to assess whether this is still related to decreased oxygen consumption. And during all of this, be aware of venous congestion. So you have your shock, you have decreased microcirculation, you have these parameters of abnormality, you get vasodilation with your treatment, and your parameters improve, your microcirculatory function improves, but with your treatment, you induce venous congestion and you increase venous pressure, which limits microcirculatory perfusion. And this venous congestion is getting more and more attention. We just recently published a study where we showed that the presence of venous congestion has nothing to do with fluid balance, has nothing to do with even fluid responsiveness. So you can be congested and fluid responsive. It has, of course, something to do with CVP, because that's a marker, or let's say a cause of venous congestion. And so don't think about fluid balance, and be careful with fluid responsiveness, because you can have a congested organ while there is still an increase in cardiac output when you get fluids. And that's why in this study, already some time ago, they said the assessment of fluid tolerance should precede the assessment of fluid responsiveness. In the paper, the previous I showed, we also gave an algorithm on how to use this. Also recently published in Journal of Critical Care, a review by Philip Rolla and Eduardo Catan, which is very helpful. Now, the value of these clinical signs was assessed in a recent meta-analysis published in Intensive Care Medicine. And they looked at all these, what's the evidence for all these parameters, like tachycardia, diaphoresis, peripheral pulse quality, skin mottling. And so they assessed all these parameters, and finally they came up with, well, basically these parameters of abnormal capillary refill, of abnormal peripheral perfusion, like capillary refill time, are the only proven parameters to be of any value in the assessment of shock. Problem, of course, is that shock is defined by hypotension and tachycardia. So there is, of course, a problem with these. But nevertheless, with the current definition of shock that we use, tachycardia, hypotension, stuff like that, capillary refill time in the current literature available turns out to be basically the only one related to shock. And that's why in the upcoming recommendations of the European Society on the definition and the monitoring of shock, we still recommend, just like in the first one, but now much more strongly than in the first one, We recommend monitoring skin perfusion using capillary refill time, temperature modeling, stuff like that. These markers of perfusion are a core element now of not only diagnosing but also treating shock. So in conclusion, vasoconstriction shut down the peripheral circulation and circulatory failure. Remember, septic shock in the early phase is also a low flow state, low cardiac output, not because of fluid loss, not because of hypovolemia, of course, unless the patient has vomited and diarrhea, but in an acute sepsis episode, it's not loss of fluids, of volume, not hypovolemia, it's vasodilation in the venous area, increasing venous capacity. There are strong clinical signs of impaired peripheral perfusion. So color, temperature, capillary refill time, very strongly related to having impaired circulation in your skin. And so low color, abnormal color, low temperature, and you do a laser Doppler flow or whatever measurement of skin perfusion, they're always low. And the goal of treatment is to adequately treat the cause of the problem. Remember, these parameters do not tell you what's going on. You have to create the context yourself. So if you lift the sheets and you see two, let's say, blue legs, doesn't tell you whether that's sepsis or cardiogenic shock. That's your task for the next few minutes. Optimize the macrocirculation with fluids first. When diastolic blood pressure is not very low, or your peripheral perfusion index, peripheral perfusion pressure is not very high. So if you have a huge difference between systolic and diastolic blood pressure, or your diastolic blood pressure is very low, your patient is likely to be very vasodilated, and fluids in those cases are usually not very effective. That's why in Andromeda 2, we would start with a vasopressor in these cases. But still, this, let's say, approach awaits validation by the results of Andromeda 2. Use a test to find out whether the patient would benefit from increased blood pressure or increased blood flow. If you did your stuff and you're not sure, then test the system or stress the system. Increase the blood pressure, see what happens. Give an inodilator, low dose dobutamine, 2.5 microgram per kilo or 5 micrograms per kilo, and see what happens. Consider the use of nitroglycerin if patients do not respond to any of this, but be careful, build your experience with this, and be aware of fluid overload with venous congestion, even if your patient is fluid responsive. And so, individualized therapy. Don't treat your patient as a group, and please forget the Surviving Sepsis campaign recommendations regarding hemodynamics, of course, as they absolutely harm patients. So a patient that is not clearing his or her lactate, the patient is in trouble, no discussion. But a patient with an abnormal peripheral perfusion is even in more trouble. And a patient with a normal peripheral perfusion is at risk of being harmed by the resuscitation efforts if you want to correct lactate, even when peripheral perfusion is normal. Thank you very much.
Good talk. And is there any question in the chat? Because we only have time for one question because we have another meeting. It's already ongoing and we have to join 5 at sharp. But we have a question. The use of nitroglycerin is very novel and interesting one to me. If nitroglycerin is not available, what are your thoughts and experiences on the early use of dobutamine when there is a high mottled skin score to improve peripheral perfusion? Would you apply dobutamine only when other vasopressors fail to improve perfusion, or would you consider using it earlier?
That's a very good question and not easy to recommend. So if I come to the bedside and I see 3 vasopressors and a blue and mottled skin, the first thing I do is turn off the vasopressor. at least half the vasopressor, because many of these patients are over constricted. That's one thing. The other thing is, if you do not use nitroglycerin, especially in the US, that will be very difficult. You can use low dose dobutamine. We have shown that patients respond to these low doses of dobutamine. You can use milrinone or inoximone, whatever you have. Also, a very good vasodilator, very long half-life, so a little bit more, let's say, dangerous. But the first thing, always consider whether you're giving adequate doses of vasopressors. I recently had a patient, and they said, "Oh, we resuscitated the patient. Blood pressure is okay. Was on 3 vasopressors. I lifted the sheets, and there were 2 blue legs. And when I stopped the vasopressor, nothing happened to the blood pressure. The blood pressure remained completely stable, and so completely over vasoconstricted. So remember, whenever you see these abnormalities, check when you're adequately treating your patient with the vasopressor first."
Thank you very much. And I have one quick question, because I really loved your comments on venous congestion, and I keep teaching to our residents that it's not the mean arterial pressure, but the mean arterial pressure minus CVP. So the difference between the two, that is the perfusion force. So what would you recommend for this pressure? 40, 50,
Oh,
30?
that's a great question, because we don't know. If you have patients in cardiogenic shock, they by definition have a higher CVP without having, at least, without clearly having abnormal tissue perfusion. That's why I use the mean systemic filling pressure, because that's the pressure closest to the organ. And so I would always try to keep the difference between the mean systemic filling pressure and the central venous pressure as low as possible. Our system in healthy people operates at the, let's say, perfusion pressure difference around 5, maybe 6 millimeters of mercury. When your difference between CVP and mean systemic filling pressures is way more, your patient is in trouble, whatever the CVP.
Okay,
but that's a topic for the next lecture.
Excellent. We're looking forward to it. Thanks very much, Jan. Have a nice day, and see you soon on one of the conferences. Thanks everyone for joining in online. Bye-bye.
Bye.